So, we will continue the discussion on the clinical trials. In the last module I have discussed that what is the basis for clinical trials, what is the relevance of the clinical trials in the overall context of the biomaterials development and in the context of biomaterials research. So, we will continue from that, and one of the things that we have emphasized in the last module is the need to conduct randomized control trials, and there are three pillars in the randomized control trials. These are randomization, allocation concealment, and third one is the blinding. Each of these concepts were also discussed with sufficient details in the last module. So, now coming to that more in these phases of clinical trials, the first important thing that I have mentioned in the last module, and let me reiterate again, that is first one is the preclinical data collection. So, preclinical data collection, that will start with this in vitro experiments, preclinical investigation in animal models. So, preclinical investigation in animal models means small animal, large animal, and to conduct this stage or to conduct the analysis at this initial stage, clinical trial registration is not mandatory. However, the critical assessment of these results, critical assessments of these results needs to be done together with clinicians. Now, to substantiate this point further, what I want to say is that for example, for any materials or any implants which are to be used for orthopedic applications. So, orthopedic surgeon needs to be involved at this stage to for him or her to understand that what is the key results of the in vitro cellular level experiments, what is the key results at the tissue compatibility level experiments in the different animal models. So, that this clinician will be convinced about the lack of any potential health risk or lack of any potential health related risk for these materials, and these particular biomaterials which are to be now which are to enter into the clinical trials are biomedically safe. So, that safety assessment needs to be done together with clinicians. Now, if the material under investigation is for cardiovascular applications, then cardiovascular surgeon needs to be involved. The same is true for the neural implant applications or neural conduits or nerve conduits, then neurosurgeons need to be involved at this stage. So, depending on, I repeat, depending on targeted application of that specific biomaterials, clinicians from specific or clinicians from the related disciplines must be involved at this particular stage. Now, once you do these things, then it will lead to the next stage will be to submit the clinical trial projects to funding agencies for financial support, as well as to submit it to institutional ethical committees as well as the national level ethical committees. Now, these things I have mentioned further, and let me again repeat. So, typically in the context of the biomaterial, it is typically known as that first in man studies. Okay. So, clinical trials this is kind of one can consider this as a synonym. So, clinical trials in the context of biomaterials is known as first in man studies, and clinical trials, the way it has evolved, it is more specifically used for drug screening or drug testing. So, clinical trials are essentially all the protocols, all the phases of the clinical trials are defined with respect to drug trials or drug screening. So, for any doctor, the clinical trial, the moment you say clinical trial, that means that it is essentially meant for drug trials or drug screening. Okay. Now, the other things from I am taking the discussion further, or I am trying to extend the discussion further from the last module. So, what I said that after all this assessment is done, preclinical data assessment, then clinical trial proposal to be submitted to funding agency together with necessary approval from ethical bodies. So, these ethical bodies, if it is to be single central limited clinical trials, then it is to be only one hospitals where the clinical trial is to be done. If it is multicentric, multiple hospitals there, then ethical committees of individual institutions need to be sought and they need to be compiled together, and then this is to be submitted further for the national level ethical committee, and then all the approvals together with this proposal is to be submitted to funding agency for financial support. Okay. Now, clinical trials theoretically can be divided into 4 phases: phase 1, phase 2, phase 3 and phase 4. Phase 1 is the initial safety investigation and evaluating dosage ranges. As I said earlier or just few minutes ago, that clinical trials are essentially clinical trials essentially started to screen the drugs. So, therefore, these phases are also defined in the context of drug trials. So, this is dosage range means if you take any single drug A. So, what are the doses, this is or therapeutically relevant doses that is to be required to start these clinical trials before it is given to a number of human subjects, that is to be done at the initial stage. So, initial safety investigation certainly does not require a large number of human patients or human subjects, but certainly very limited number which may give you statistically relevant results. So, here comes the importance of the involvement of biostatistician in the clinical trials. So, any clinical trial study needs to be, or any research team which will conduct the clinical trials must involve biostatisticians, because statistical relevance or statistical significance of the patient's outcome results need to be analyzed with the help of the biostatisticians. So, as I said, the number of human subjects to be just appropriate or to be minimal in number, but at the same time that minimum number of human subjects should give statistically significant or statistically significant results. So, therefore, I have emphasized this part here again. Second one, so now once the phase 1 study is done, then phase 2 study can be initiated or can be planned, and phase 2 study involve initial efficacy investigation and further safety assessment. Now, if I recall or if we recall our discussion in the last module, I have mentioned very categorically that phase 2, phase 3, phase 4 essentially depends or each time a clinical trial experiments enter into a higher phases, let us say phase 1 to phase 2, that essentially means more number of human subjects are involved, or in other words that this efficacy of that particular disease or particular disease treatment is now validated with a larger number of human subject population. So, that once it is done completely, then people can really believe the results of this particular treatment. So, let me take a blank slide and this explain to this one in little bit with little bit more clarity. So, let us say this is your preclinical experiments and this is your clinical trial. So, preclinical experiments, if you remember that I have emphasized that you have to start with small, medium, and large animal model. And this small, medium and large, essentially you are doing the validation of lower level animal experiments. And there I have mentioned very clearly that as the size of the animal increases, the complexity of the in vivo physiological environment also increases, and also the ethical committee approval, animal ethical committee approval will become more and more difficult. For example, if you go to rabbit to dog, animal ethical committee approval would be more difficult. If you go from dog to monkey, animal ethical committee would be animal ethical committee approval would be even more difficult, because you are now carrying out the experiments with primates. So, in case of using the primates or larger animals, animal ethical committee approval would be much more stricter. Similarly, now if I may kind of compare that some kind of correlation like phase 1, phase 2, phase 3 and phase 4 clinical trials. So, as you enter or as you travel along this direction from phase 1 to phase 2, phase 3, phase 4, number of human subjects increases, and therefore, the ethical approval becomes more and more difficult. So, I repeat my statement. What I said is that this each of these phase 1, phase 2, phase 3, phase 4, if you enter from phase 1 to phase 2 trial, then essentially that means more number of human subjects are now involved in phase 2 trial compared to phase 1 trial, and the same is true for phase 3 compared to phase 2 trial. Now, if any clinical trial involves only the phase 1 trial, the ethical committee's approval is absolutely necessary, but it may be little bit less strict or less difficult compared to the case when one is planning to conduct clinical trials up to phase 3. So, first of all, one has to conduct first phase 1 trial completed, then they have to take approval for the phase 2 trial based on the satisfactory outcome of the phase 1 trials from the patients who participated in the phase 1 trial. Now, same is true for if you enter to phase 3 trial or phase 4 trial. So, I hope I have kind of made this point relatively clear to you, that what is the rationale for going from 1 to 2 from one phase to another phase of clinical trials. So, let me go back to this discussion further. Now, I have mentioned that rationale for going from one to another phase. So, phase 3 essentially means extensive exploration of efficacy and safety in a larger population. So, if your phase 1 trial involves let us say 10 patients, phase 2 trial should involve 50 patients, phase 3 trial should involve maybe 100 patients or 150 patients. And phase 4, it involves post market evaluation of the drug, like already drug is marketed in the real world, and then how these drugs are kind of used by the people in the society and what is their health conditions and how certain diseases are now treated in a much better manner compared to the earlier one. So, all those evaluation needs to be done in phase 4, but normally most of the clinical trials are done up to phase 2 or in some cases it goes to phase 3 trial. So, once the phase 3 trial is done and then clinical efficacy or clinical safety, earlier you have done just biomedical safety in the preclinical stage in the animal models. Now, you are conducting clinical trials, you are essentially assessing clinical safety or clinical efficacy of that particular drug or of that particular implant to treat certain human diseases. And once that is completed, then this implant can be commercialized through some biomedical entrepreneur or certain orthopedic device companies or other device manufacturing companies. Now, before I complete this this discussion on these clinical trials, let me give you some examples of that how to design this kind of clinical trial study. So, this is with respect to one dental implant for prosthodontics. In prosthodontic applications. So, as I said that it is a common thing about, or it is generally recommended always to conduct the clinical trials following these randomized control trials and according to the CONSORT guidelines, which I have mentioned in the last module. So, stage number 1 or not phase 1, it is stage 1. Phase 1 of this stage 1 is that ethical clearance from institutional review board, and if it is a for dental applications, when the implant is not inside or not implanted, when the implant does not go well inside the body, but it stays at the external side of the human, like in the tooth, let us say in the case of tooth replacement or the dental implants. So, there stricter clearance from the institutional review board is sought to get the clinical trial registration. The next one is that conduct of equivalence and non-inferiority design and selection of patients. So, their inclusion exclusion criteria needs to be clearly mentioned, like what is the patient's age group, whether it is gender male female, and then whether the patients will have should not have any systemic diseases, that needs to be defined. So, that means that when this particular age group, so as you can see that age group that needs to be selected over a broad range, not a very narrow range of the patients, like 15 to 50 years is a relatively broad range of age, and in this age group the clinicians or the investigators who are participating in the clinical trials do not have any choice of the patient that they would recruit. Any patient who wants to voluntarily participate in the clinical trials in this age group, in principle should be recruited in the clinical trial study. And as far as the gender also, there should not be any bias. Now, all these biases would be ensured if one follows randomized control trials, because if you remember in the randomized control trial the 3 pillars are there. One is called randomization, second one is that called allocation concealment, and third one is called blindness. So, once these 3 concepts are in place, or when these 3 things are followed very critically, then all these other things would be taken care. Then in the particularly for prosthodontic treatment, one can have additional criteria that the patient who is recruited in this study, there should be at least one or two tooth that should be absent bilaterally in maxilla or mandible, and then the patient's outcome or the success for the clinical trials needs to be quantified, needs to be defined either quantitatively or qualitatively. In often most of the clinical trials, people do people put lot of effects, people put substantial efforts to qualitatively evaluate the outcome results rather than quantitative. But as the field has progressed over last few decades, these particular materials for biomedical applications, people start using more quantitative tools to estimate the efficacy of the clinical trials or to quantify the efficacy of the clinical trials. Just to give you this example, after these certain dental implants is inserted into some patient having patient following the criteria which I have discussed just few minutes ago, adequate bone width or bone height and width can be measured using CBCT technique. CBCT is convergent beam computed tomography technique with 4 months post extraction healing time. What it means that after the patients receive that implants, there should be a gap of at least 4 months, then the patient would visit the doctor again, patient would go to the hospital to the same clinician, then the clinician will use this convergent beam computed tomography technique and quantify that what is the bone width or height around the implants, and that quantification will be able to give the clinicians some confidence, yes, these particular dental implants which were implanted in this particular patient provide satisfactory results. The other things that I have mentioned towards this end of the slide is that adequate sample size calculation. Here sample size means it is not a typical material science sample size, but it is in the context of human subjects again. Now, sample size for a power of 90, this is like typical language they use, clinicians they use, like 46 patients that needs to be recruited in this single centric clinical trial experiment, clinical trials. Now, considering 15% dropouts, what is the meaning of 15% dropouts? Like you start with 50 patients and you expect all the 50 patients need to go through all the advice, suggestions and need to undergo all the investigations as laid down in the clinical trials. But it may so happen that 15% of the initially recruited patients would decide that they would not undergo all the clinical follow up or all other clinical testing that is required or that is suggested in the clinical trial study design. So, if those dropout cases, even if those dropouts, those patients they will drop out from this clinical trial study, it is the moral responsibility for the clinicians to follow up those patients, so that once they have received that particular implant, that does not cause any undesired or any any undesired effect in the patients as far as the patient's health status is concerned, and that should not be clinically significant. And if those dropout cases also the results are clinically significant, that means patients develop certain side effects because of that implants, patients develop certain other complicated health related effects because of the because they have undergone that particular implant, they have undergone that particular treatment or received that particular implants because of that particular reason, then those things also need to be critically considered while analyzing the total results of the clinical trial. So, let me summarize therefore, that it is important to select the critical number of human subjects, so that it provides statistically relevant results, but at the same time one has to ensure that sufficient number of patients will undergo this, who will undergo the clinical trials, will participate all the follow up study, will also participate all the clinical investigations as suggested or recommended by the clinicians or investigators who are conducting these clinical trials. And even in case of the dropouts, like the patients who discontinue to participate in the clinical trial study, their health status, their health condition needs to be monitored till the time the clinical trial study is over. Once it is done, once it is ensured, all the results together should be analyzed, so that one can critically conclude that what is the outcome of this particular clinical trial study. Okay, so this is that second last slide, and this is so this one, it has been mentioned that design of randomized clinical trials in the context of the dental implants in prosthodontic applications. So study design wise, that parallel or split mouth design, that is a typical that is typically followed in most of the prosthodontic clinical trials. And initial testing of the new technology needs to be done, like for example, if you are using titanium 6%, aluminum 4% vanadium implant, and if you have a commercial implant, and then those initial testing needs to be done. Okay, proper randomization, allocation concealment and follow up of dropouts needs to be taken up or needs to be ensured, as I said, because proper randomization and allocation concealment already are two verticals of the randomized control trials. So, in the RCT, these two are the two verticals. Third one is that endpoints, that is the implant supported cement or screw retained in prosthesis for single posterior tooth replacement in function or for at least a year. What it means, all the clinical trial study is over up to the 4 months, they would do some kind of a quantification of the bone regeneration around the implants, but at least it needs to be ensured that the tooth which has been replaced by this dental implant, that will remain there in a functional conditions for at least 1 year. So, let me tell you this in this last slide is that how to ensure that what are the qualitative and quantitative outcome measures. These outcome measures are the kind of results of the now in a typically material science, when you develop some materials, one does X-ray diffraction study to see that what are the phases that is there present, one does microscopy study to see that what is the morphology of these phases, what is the composition of the different phases locally and so on, and the same time people do some kind of mechanical testing just to see that what is the strength of that material. But those kind of conventional characterization or conventional testing is not possible in case of this kind of clinical trials, although this should be done in a scientifically appropriate manner, but instead, as I have explained in this slide, that there are certain patient oriented outcome that needs to be measured. First one is the oral health quality of life or patient satisfaction. After they receive these implants in the after the patients receive these new implants, patient satisfaction needs to be first qualitatively recorded, whether the patient is complaining about the tooth pain or about some inflammation or about some uneasiness, or they have difficulty in chewing food or certain masticatory reactions, whether those things are there, that has to be recorded, and that has to be scored in terms of some qualitative manner. Is it like +1, +2, that is called Kimi score, scoring effect and so on. Second one is that implant supported restoration for the dental restoration, like what is the longevity of restoration or technical complications. Third one is the peri-implant health, like whether there is a marginal bone level and probing depth of the soft tissue, this can be investigated. And fourth one that I have mentioned, which is more quantitative estimation, that osseointegration, like this implant which is inserted into the mouth, how well it is integrated in the osseous system around the implant. And here it is the cone beam computed tomography analysis needs to be done to quantify the hard tissue stability and at different time level. So, this is that at different time plan about time at the different time frame, like 4 months, 12 months post implantation. That means after the patient receives this implant, so after 4 months, because 4 months is the time that this new bone or new tissue is expected to develop or mature around any orthopedic implant. So, similarly for dental implants also it is true, particularly the human patients. And then 4 months and 12 months they should see that there is no radiolucency and there is continuous bone formation around the implant. And last one is the primary stability at the surgical placement. This aspect can be assessed by resonance frequency analyzer. So, this is kind of relatively newer technique, and then with all these results in hand, that is to be analyzed together to validate the outcome measures. That means that what are the patient oriented outcome measures, and if it is acceptable to the clinicians, then this particular implant can be commercialized in the market. Okay, thank you.